Welcome to our inaugural episode of Virtual Care Leadership. I'm really excited about this particular series on many fronts, and I can't think of a better person with whom to start this series with, and that's Dr. Ram Raju. And I'll let Ram introduce himself in just a second, but what this is really about is what is the impact of virtual care going forward from a leadership perspective, and not just from a CIO perspective, but from healthcare leadership, from the C-suite. And Dr. Ram Raju, as you can read, and as he'll introduce himself, has been a longtime CEO and also executive member of some of the foremost health systems in our country. So I'm really excited to have him here. And let me tell you about my first encounter with Dr. Raju, and then we'll allow him to introduce himself and get right into the topic. So I recall that a few years ago, I was recruited by New York City Health and Hospitals to help with some early digital transformation efforts, and the driver brought me to Health and Hospitals headquarters about an hour early. So I think I had a 7 a.m. appointment interview, and we showed up around 6 a.m. The driver walks into the CEO's office, and Dr. Raju's sitting there, and without losing any momentum, he just took me right in, didn't make me sit out in the lobby, but took me right in. We had this great, wonderful chat until my 7 a.m. appointment showed up, and then we did some amazing things. And so I just want to say thank you, Dr. Raju, for your leadership, especially while at New York City Health and Hospitals, which is along with Northwell, but certainly Health and Hospitals at the epicenter of, if you will, of COVID. And I think because of the leadership you brought to Health and Hospitals in ensuring the digital transformation that occurred while you were there.
Charles Schwab, yes.
What's happened since then in terms of the response. So without further introduction, let me just welcome Dr. Raju. Would you mind telling us a little bit about yourself?
Thank you, Ed. It is such a great pleasure to see you and talk to you. And it looks like yesterday. That's simply because yet I have insomnia and I wake up at 3 in the morning. So I have nothing else to do than come to the office at 5. So I had a great opportunity to meet with you first before any of my team members could interview. So thank you for your greatest help with the Health and Hospital. And due to your pioneering efforts, the system is doing very, very well now, completely digitalized, and it's really done wonderful patient care activities since that transformation occurred. So I'm a surgeon by profession, and the first 20 years of my life, I practiced vascular surgery and trauma surgery in some of the academic hospitals. And like anybody else, my concern was always medical school, teaching, academic rank, research, residency programs, and subsequently in 2000, I went and got my MBA, and subsequently moved into an administrative role. And my work was always on health equity and disparities in healthcare. And I always wondered why the outcomes are not the same for everybody in this country, because the doctors in the system don't discriminate. We give the same medication and same treatment for everybody, but there are the people who live in the wrong side of the train tracks, or they tend to live less, and then the people on the right side. And that basically started the concept of zip code matters. Where you are, your zip code determines how long you will live. If you happen to be in the south side of Chicago, your average age is 67. And if you move over to the north side of Chicago, you live till 81 years old. So there is something in the geography which makes a difference. And that journey took me in the last 20 years, and moving on to, it could be access, it could be, the reason why certain groups of people are not really getting the benefits and outcomes they deserve in our health systems because of their access. So we improved access. Then we thought it was clinical competency, able to understand their needs and beliefs better. So we did that. We want to integrate them into the healthcare delivery system by doing more and more of what we call as inclusion and diversity. But All these things helped a little bit, but didn't really crack the nut. So eventually, about 6 years ago, some of us in this country landed on this concept that what matters is really where you live, and the social, economic, and the environmental issues you deal with. So subsequently, there was a study published that only 20% of the outcomes of any disease is related to the clinical care we get, and 80% is non-clinical care, and 40% of the 80% is really healthy behaviors due to health literacy, and the other 40% is the socioeconomic and environmental factors. So that has been my journey, and that's what I'm doing right now in Northwell, trying to understand the community's social risk as well as the social risk for the patients. So we have developed a risk score for the patients. So as the patients are being treated by the providers, a screen pops up about their social risk factor, and they get referred to appropriate social service organizations or community-based organization to address the social issues like the food insecurity, transportation needs, public safety, homelessness. All those things which identified as a risk is being tackled outside the health system, but through the health system computer system. So that's what we do now, and it has been very exciting to look into that. So with that, we have really entered a new normal in New York City because of the COVID-19, which is really kind of devastating the New York City, and we are all kind of shut in, and the healthcare workers in our system and all systems across New York City are doing a fabulous job putting themselves at risk and trying to save the patients from this pandemic. But what we have done is we are seeing some light at the end of the tunnel. We are kind of crossing the apex and moving on to the other side of it. So yesterday, the number of deaths have gone down significantly, but still, even one death is more than we can accept. But we are really in the right channel, on the right track right now. So hopefully this will help us. So with that in mind, I will hand it back to you, Ed, for your questions.
Yeah, no, that's a great introduction. And for those who don't know, Northwell is actually the largest health system in the New York City, the greater New York City region. And I love what you say about there's no health equity without social equity. So we're going to weave that in our discussion on virtual care. This is live, so the reason we do it live is it makes it a little bit more fun, I think, for us. But the main reason is that it's meant to be interactive. So you all know how this works with GoToWebinar and those sort of tools. You can feel free to enter in questions. We'll try to get to as many questions as we can in our limited time. And yes, I think we've solved the mute issue, but if you are not on mute, we have put everyone on mute so that it makes it a better quality listening experience. So, like as you mentioned, Dr. Raju, you oversaw the building of Digital Foundation while you were CEO at New York City Health and Hospitals, and then moved on to Northwell with the focus on community health. As a longtime executive and leader in the New York City region, I know a lot of listeners are wondering, and again, we're going to weave in the virtual care here in a second. But can you share some perspectives on the pandemic and how your health system and others are sort of working together, and then any sort of digital technologies, virtual care technologies like telehealth that you're all deploying to help with the situation?
Sure. Northwell has been one of the leaders in telehealth for at least, I would say, 10 years, and we have really done a lot of job. But usually, it is being utilized for management of chronic diseases and the ability to manage them. With this, stay-at-home kind of policy, we have started using more and more telehealth for the people talking to the primary care doctors. Not only Northwell, most of the other organizations have started talking to the patients. Even if you think that you have a virus, then the best thing is you don't come to the ED. Just have a chat with the provider, and then the provider asks you a few questions, and then you could do a couple of things, then make a decision whether you should be seen or not to be seen. Right? That is there's more use as a triage, so that we are not flooding the emergency department, because that becomes a bigger issue for us, because it kind of spreads the virus. We don't want people who are worried well and not coming to the ED, who are not infected will get infected. So this pandemic has really changed the way we practice this medicine for a long time to come, and I'm pretty sure that is going to have a lasting effect in New York City's healthcare market as well as in the rest of the country. People are really, even though we have telehealth and teleradiology and telepsychiatry, all of them are very popular in Northwell. We still, there was a lot of an acceptance. The patients were not there. The patients were still in the old-fashioned way. They want to see a doctor. They want to talk to a doctor face to face. They won't deal with that. This forced acceptance of seeking and talking to doctors through the care actually made the patients more relaxed, and they said, okay, I can do this through the television. I do not have to see a doctor with that. And that is not going to change. That is going to take off into the future, because people are going to say, wait a minute, why do I have to go and wait, travel all the thing is New York City travel, go and sit in a place, wait for the doctor, wait in the large waiting room. Then I go and sit in the small waiting room to wait for the doctor. Finally, the doctor comes in there and he talks to me and answers a couple of questions, just a little examination, and then tell me, okay, come back in 6 months. So, or take this medication, or do this lab. So people are this forced acceptance of virtual care has completely altered the way the providers are doing that. And the second major impetus to this virtual care right now is the government said they are going to pay for it. And that is a very big impetus. People are saying, well, because a lot of people at some point, some insurance company pay, some people don't pay. And now it became more and more as a norm. Yes, you can get paid if you do virtual care as a part of it. That became a very big issue with that. And the third is the perception of the care has also changed. People felt that, I can really have a good discussion with my doctor, and I can have all these gadgets which are attached to my computer, able to measure my blood pressure, measure my weight, and my blood sugar. All these things could be helpful to me. So it has really changed a lot of ways of doing that. So we are using telemedicine and virtual care, exclusive in many places. And I think that is going to really take off, and the way that will be a major disruptive influence in the way we practice healthcare in New York City for years to come.
Yeah, I would agree with you as an observer from the outside, but having a little bit of experience, and I think that will change the practice of medicine, as you say. We're getting a ton of questions, so we're going completely off script, which again is the fun part of being live. And but at least the first one here is headed the direction we're headed anyways, with social disparities. You talked about the zip code and where you're born has an impact on your health. How do you foresee, and I think you touched on it a little bit in the very beginning, but how do you foresee using more digital technologies in order to change that reality of the disparities?
This is a very, very difficult and tricky way of dealing with that, right? When this pandemic came in there, in the month of February, some of us in this country started saying that people who are medically vulnerable, if you're over age of 65, you have diabetes, high blood pressure, kidney disease, you have lung issues in the past, you are high risk for this virus and high risk for mortality with this virus. Some of us saying that, yes, you are right, but we also have socially vulnerable people. The people who are really socially vulnerable, people have poor literacy rate, people have poor income, poverty, people who cannot get the food in the areas where they live in a food desert. They don't have transportation needs because they have to really take a crowded transportation. All these people are going to be more affected. So though the COVID-19 is supposed to be equalizer, it is equalizer in the sense that it affects everybody, but the outcomes are going to be very different for different people. So it took nearly a couple of months before people started raising the question that somehow the minority communities in this country are disproportionately affected and disproportionately they die of the disease compared to the majority population. So if you look at it, people always said, oh, that is because the minority communities are really have a more health burden than other people. There are more diabetes in their community. They don't take care of themselves very well, which is true because the healthcare delivery system has kind of never created health equity in the last 50 years. So there are people in this country who happen to be in a rural area. They could be, it's not really, it cut across even the race and ethnicity. It is, the white Americans in Arkansas and Mississippi Delta is as poor health as much as, a black population in south side of Chicago or the Hispanic population in Bronx. So it is really a bigger issue than that. So healthcare, yes, healthcare disparities due to high health burden of this community is a real factor, but we also believe the social issues make a difference. You cannot do social distancing if you have to travel by subway because you have to go to work. Most of the frontline workers, the grocery store, people who package the bags and they deliver the goods, they're all mostly minorities in this country. And they have to travel. And you cannot practice social distancing in the subway. If you live in a housing apartment, in a public housing, and you have only one elevator, you live on the 14th floor, you cannot, and there's only one elevator working, you cannot do social distancing. And the health literacy, I always complained about it because you have to be either to listen to the local governor or the mayor or even the president to listen to their news conferences, which are very good, but you have to have at least a college education and know English. If you happen to be health literacy needs, you will not be able to deal with that. So Northwell we used our platform. We worked with a company and we created what we call as a chat box, which basically creates the message, and the message can be downloaded in the smartphone by an app at the literacy level. If you read it and you don't find it at the literacy, you can make it 5th grade literacy level, the same thing. It could be translated in any language of your choice. And it's also be obtainable through the medium of their choice. Some people are visual learners, some are auditory learners, they listen to podcasts, some people are really read a paper, right, a brochure. In healthcare, we never did that. We always gave them a piece of paper and say, please read this and follow the instructions. If you happen to be a visual learner, that's you don't learn anything out of it. So we have created the digital platform to create health literacy so this is available to you in the right time, interactive, at the literacy level of your choice. You can control that. The medium of the choice, right, whether you want to be audio, visual, right, whether you want a paper, and it will be a choice of your computer versus web page versus your smartphone. We use smartphone exclusively because we believe more people have smartphone in this country than computers. And it is also, you can also translate the language of your choice. So once you do that, we started seeing a tremendous, compliance with some of the things we want them to do. Social distancing, how to walk, how to cough when you're coughing, how not to, shake hands, how do you wash your hands effectively. All those things are health literacy issues. And that is an important part of controlling the disease. And that has to be delivered to them in their language at the literacy level through the medium of their choice, and so that they can be able to be helpful to that. So that is what an important aspect of it. So though we continue to see the people who are really, in the shadows of the community of the society are affected more by this, because in normal peace day they are already in deep trouble. On a pandemic, they usually get affected more than the people who have got things to do. People can, stay at home because you have a big house. You could do social distancing. You have 10 rooms, so you can always stay in different rooms. But when you are living in a apartment, there's one room and 6 people in it, right? And you live in a food desert where there's no grocery store available next to 4 miles next to you. And you have to take the transportation to work, or you have to take a transportation to get groceries, right? All these things are very, very important. So we tell people, just do that, stay at home. It is not, because people live from day to day. They depend on daily wages. If they don't work, they don't get money. And how are you going to get the money? How are you going to get the feed them? So these are all some of the, so we created what we call social risk, like medically risk community. We need a social risk community. So we started asking our COVID patients when they come in, you have food insecurity at home. If you have food insecurity, you have nothing in the fridge, we're going to give you food when you leave, making sure that you have enough food in your house so you don't have to go outside and try to find it. So those kind of stuff, right, are so important to us. And the digital platform has helped us tremendously connect with these people much more better than we would have otherwise done.
No, that's very good, and there's a lot of chatter about some of your comments. Very, very helpful. So thank you for sharing that. Gold mine of information right there on how to approach it with a multimodal, omni-channel type of approach, and really leveraging the digital capabilities. Someone had a question about, and I have an anecdote as well after you answer the question. What about seniors? And I know obviously you're targeting seniors, but as you mentioned, Northwell's been a long time leader. So even pre-pandemic, a long time leader in telehealth. Are you seeing much adoption in the actual video capabilities of telehealth with the senior population? If it's been a problem, have you done anything that might have addressed it to make it easier?
You know, it depends. There are seniors who are very computer savvy. They're pretty good in doing that. Then there are seniors who really cannot have either cognitive ability or they need other help to monitor, to navigate the computer. So that is why I said our experience has been, right, since we only used it mainly for, triaging patients, just giving them advice and education and the literacy through this virtual care. We have never really before this in the pandemic, we never used it as a big modality to do that. The only area where we used it very, very well is telepsychiatry, because we have a lack of psychiatrists in New York City. So we basically felt, so we set up what we call as a situation room kind of in one of our Manhattan areas, where we are able to do telepsychiatry from people from Suffolk County in Long Island, because it's very difficult to sometimes attract psychiatrists to some of the outer counties, because that's not what they do. A lot of people want to live in Manhattan. So we are able to do telepsychiatry. Telepsychiatry was extremely helpful. An on-call system was very helpful, right, as a part of it. And it was also mainly used by care coordinators and and also social workers. But the real care delivery was kind of, it is starting, but it is not, catching on as much as we would love to do that, because of the different skill sets of the seniors we deal with. There are very different seniors we deal with, and that is something we have to be very cognizant of, right? Some of the seniors, it is very difficult to, get them to navigate through these things, and some of them are not. So
No, that's a good point. It was funny because every Sunday we do a family check-in with my family around the country, and my dad, who's in his upper 80s, he's actually been using a smartphone for many years. I think we got him an iPhone, 7-8 years ago, and he's quite adept at Facebook and things like that. But we thought just hitting a link would be easy enough for him to pop up. He struggled with a little bit, so someone had some questions around that. And like you said, you just have to offer multiple modalities, and for those who can take advantage of the visual, obviously that's really important because of all the things that you can see that aren't said. So we're running short on time already. It's amazing how fast these times go by. There's several more questions. There's a last opportunity for those of you who have a question for Dr. Raju to ask them. We don't talk about vendors specifically. There's some vendor questions, but I will follow up with everyone who had a vendor question and let you know about the particular vendors that may have been, their attributes may have been discussed. So Dr. Raju, about a third of our audience comes from the vendor partner community, about a third are C-suite, and another third are IT. Here's your opportunity to speak to some of my colleagues on the IT side of things. As a health system executive, and like we'd mentioned, CEO of New York City Health and Hospital, Cooks County, some of the best public health systems in the world. What would you say from an IT perspective, and keeping in mind the pandemic, but beyond that, with the whole virtual care, the post-pandemic, what would be your counsel as a leader that how we might, I want to keep it open-ended so you can answer, you can take it any directions, but what is the ideal circumstance? What do you want to see from your IT leader? What sort of maybe technology or way of work? Again, open-ended, but always good to hear from a longtime leader.
Sure. I think now this is purely a speculation on my part. I think this particular pandemic has opened tremendous opportunities for IT companies to really carry the virtual care to the next level of able to deal with it. So there is a lot of opportunities of able to really examine the patients, take their vital signs and getting the test done. To a great extent, a lot of other things could be done through the virtual care. I will at one point I will even be surprised. I will even be not be surprised if you see people are able to do a sonogram. Just if you want a gallbladder, just take a sonogram probe attached to your computer, just put it on your thing, and you can take a look at it. It may come to that. I don't know, right? So there's a lot of opportunities for you to do that. So what we want from healthcare is there are only two major areas in which IT has been extremely helpful in healthcare, right? Of course, they have the EMR, which is an issue. And second thing was on the financial side. Most of the IT things are revenue management cycles are part of it. But what we need more, the first thing on the revenue management side is the future is all about, because the revenues are going to get fixed, especially in the post-pandemic, it's going to be very tight for money. So we need more and more understanding of our cost structure. That is more important. So we need, there's an opportunity for IT companies to create managing the cost, right, of the care as much as, just where can we get more revenue, right? That is, the shifted tremendous, that's one. The second thing will be that we need more and more of patient-facing IT technology, which makes their life easier, and it is also convenient for them to do that. And this also do not have a lot of what do you call it? Is not error prone, right? The reason is, I just kind of take this opportunity just to look into that. Having lived through this, when Amazon first came in there, I only ordered a few things on Amazon, which are just like a commodity, like a toilet soap, or is it something which is available in there. I would have never got shoes in Amazon, because at the time my perception was, if I want a shoe, I got to go, feel the shoe, wear the shoe, walk on the thing, and see what happens with that. Now, for the last 10 years, I never even bought a shoe in a shoe shop, right? Same with my dress, my shirts, right? And people told me you can never get groceries in online, because if you want to go to grocery store, you have to feel the grocery, you have to squeeze the tomato and see whether it is firm enough to be into that. Now, in the pandemic, more and more people are getting grocery by either Amazon Direct or Peapod or whatever it is. So it is complete, the perception of what could be done through this changed tremendously. And that opens up a great opportunity for the IT vendors to create some very meaningful, easy to handle health management solutions for them, right? So I think that would be the greatest opportunity for you to do that. On that one, I also have a plea. A plea is that, as we do these things, we cannot deliver healthcare in isolation, and if you want to really create healthcare equity and healthcare outcomes in this country, you really have to also manage a patient's social issues. Unfortunately, healthcare, we have come to the situation where we know more about the diabetes of John, and we know less about John, who has diabetes, and we have nothing about where John lives and what he does, because we have kind of moved, we depersonalized the medicine. So hopefully this will bring us back into the total holistic care of the patient's condition, the patient himself, and also the situation in which they live. It makes a difference. You can never ever control diabetes without having a food insecurity addressed. If you don't have the right food to eat, you cannot control. We have tried all our life to control the social issues by more medications. If your blood sugar is not under control, we assume that it's because you need more medication, whereas you probably need better food to eat. So those kind of things will change the way we encounter. The last but not the least is healthcare is only a very small percentage. Health is a major percentage. So we need more and more, health opportunities to create, to do that. Now they are doing a little bit on Fitbit. They did some food. Then they have some of the companies are done, virtually the exercises and food and everything else. But there is a great opportunity to create more health innovations. How to keep people healthy, because as the people live longer and longer, they want to be healthy and fit, and that gives another opportunity for you to do that. So don't focus on purely on revenue cycle. Focus on cost structure. Create some health apps which makes people healthy and fit. Makes app easy and patient facing, and create some app which measures the social risk factors as well as the clinical risk factors.
Yeah, this has been, as I expected, amazing. I was even taking notes because I was like, oh, I gotta make sure I address these sort of things in our own practice. So thank you so much, Dr. Raju. It's so good to reconnect with you. Like I mentioned, I've thoroughly enjoyed our opportunity to serve together, and thank you and all your team at Northwell and former team at New York City for what you're doing in the fight in the pandemic at the epicenter. I know the entire world really appreciates what you're all doing. So thank you so much.
Thank you very, very much. And thanks for the opportunity. And again, thank you for your greatest effort to move the healthcare delivery system in New York City to a greater level, better level. Thank you.
Thank you. And with that, we're going to conclude our next webinar. I think we have a slide on when that next webinar is coming up. This is on our Leadership Insights track, and that'll be with Russ Branzell, President of Chime, on April 29th. Thank you again, everyone, and we'll see you soon.